Welcome back to Open Your Eyes on this lovely Wednesday morning. We had two wonderful conversations so far, about to jump on into another. Actually, we've got visiting with us from the Dangriga Cancer Center is none other than Dr. Ellsworth Grant, who is an oncologist.
Yes.
Good morning, sir. It's so nice to have you.
Pleasure.
And welcome.
Thank you so much for the invite. A hematologist as well.
Yeah.
Oh, cool.
And founder of the Belize Cancer Center as well in Dangriga, one of the co-founders. We appreciate you being here
Yes,
and welcome
very much.
home, at least temporarily, right?
Thank you. Always good to come home.
In terms of health is always priority A, and we know for a fact that you work very hard. You wear a lot of caps. What is it like for you? And I'm asking this from the standpoint of health. What is it like for you when you get back home trying to unwind on a basis?
You know, unwinding when I come home is kind of difficult because I primarily come home to work.
But it's a healthy thought.
Yeah, no, you know, winding down really, as you said, it's a thought, it's mindset, and you could be sitting down but have an active mind and you're not really relaxing. So I think you need to have a commitment to yourself to relax and take time out for you. We often say, live every day, live the moment, and it's something very difficult to do. So I just try to stay in the moment, and when work is there, I work, but when it's time to just unwind and move away, I unwind and move away and make sure I get enough exercise. People who know me know they'd say I eat weird, but
What is we eat weird?
I don't think I eat weird. I'm a pescatarian. I
Okay.
haven't eaten meat in over 20 years.
20 years?
20 years. And when I say meat, there's no chicken, no turkey, no
Just
meat.
fish.
No pigtail?
No, I haven't had pigtail probably over 30 years. And you know, but part of that commitment to the way I eat is really related more to what I see on a day-to-day basis. And I think while you can't really say that XYZ food causes cancer, I think it contributes. And I always tell patients there are two sides to a diet. One is what you eat, and the other piece is how much you eat. And sometimes even if you have the what part correct, just because you have that, it doesn't mean that you have a mountain full of food.
Yeah, if you're having big portions.
Yeah, so it's striking a balance of just portion as well as the what.
I'm sure a lot of people are interested in knowing the diet of an oncologist because you have all the research to back it up. But I want to backtrack to the Cancer Center itself. It's over 10 years since you first opened the doors to what was Belize's first cancer treatment center in your old family home in Dangriga.
Yes.
And I want you to take us back to that time when you first made the move. You've been working in LA, you and your cousin, and you decide to come home and establish the center. You know,
it's a time in just looking around in the country after coming back home and hearing stories of people that, to me and my cousin, it was really a crisis, and something had to be done, and it was a matter of a lot of just heart and soul in getting it done, and I'd be the first to say that we walked into something a lot bigger than we expected, and I never really thought that the problem was at the magnitude that it is, and it's still a huge problem within the country.
Yeah. And from 2008 to now, people travel to Dangriga, Belizeans travel to Dangriga to access chemotherapy, some consultations with you, even through, I know, video conference. Talk to us about the services you've offered and how the center's grown over that time.
Over the years, it's the number of people that we've seen has grown exponentially. I think we currently do about 600 chemotherapy infusions per year, and some of that is divided in adults and some in pediatrics. Wow. Some given with the intent to cure individuals, some given with the intent to extend the lives of individuals living with with cancer, and people now are living longer with a cancer diagnosis. I think some of the proud things that we have done has really been in the intervention in pediatrics. And although I am not a pediatric oncologist by default, we ended up being a pediatric center as well. And so we service those children. And our nurses, Sister Roby and Pauline, have been exceptional in dealing with the children as well as adults, in trying to ensure that when you visit the center, you have a place that's welcoming, a place of warmth, and that you could feel comfortable, and that when you leave, that you felt your needs were addressed.
Yeah. There are many forms of cancer, but what have we seen here at home that has arisen so far, especially since you got started in 2008? What have we seen so far?
Since the inception of the center, breast cancer as well as cervical cancer have been the top 2 cancers within the country for us. And it's sad to say that although both diseases have early detection methods, pap smears for cervical cancer and mammograms for breast cancer, you still see a lot of cancers that are fairly advanced stages, a lot of stage 3 cancers, and the later you present, the worse chance you have of having a good outcome. And unfortunately, we tend to see women with very large breast masses and cervical cancers that are pretty large as well. And it's your first mammogram or your first pap smear should not be the one that diagnoses you with a cancer. And I can't preach it enough that we really need to focus on the attention on early detection and just drill it home. I think there are multiple reasons why people don't access services, but there's really not any good reason that I've heard that they shouldn't.
So we're just simply saying that people are actually reluctant in going out to check. Do you think this is because they don't know how to, especially if they want to do something I'm saying this from the standpoint that probably they're reluctant to even want to go to the doctor. Lack of resources, lack of money, but there are ways to do checks, especially when it comes to breast cancer. There are ways to do checks. Do you think it's because they don't know how to?
I don't think it's not knowing how to. I think some of it is rooted in culture. I think some of it is, I'd even say some of it is rooted in privacy, in that sometimes in accessing healthcare, that your business doesn't really stay your own business, that people end up knowing your business. And I've had friends who have told me that they have not gone, or they go in an area different from where they live, just because they don't want people to have their business out there. But privacy is a big issue, and we make it paramount at the center to maintain the privacy of people. But there's really not any one great reason not to access. I think having more mobile, if there was a more mobile mammography unit, that would help in bringing the mammograms to the people.
Yeah, that's true.
That's interesting. I've always been fascinated by the fact that there is a lot of stigma around people who are diagnosed with cancer, whether self-inflicted or just the perception of the stigma they'll face. But I want to ask, based on your professional experience, so you see the landscape in the United States where you work, and you're also very well acquainted with the landscape in Belize. What's different and what's similar?
I think the major difference is how healthcare is paid for. And where in my practice, the 98% of individuals accessing healthcare have some form of insurance. And so the issue of getting diagnostic services, getting things paid for, is not really an issue. Whereas here within Belize, money tends to be the driving force, in that it's a pay-to-play system, and so if you can't pay, then you don't play, and even the people who have money, treatment for cancer or anything else can exhaust your funds fairly rapidly. So for us, we really need to be mindful about how the money is spent on on healthcare and what services, what lab tests, what x-rays do you really need.
Yeah.
And sometimes we have too many unnecessary things that don't really help you. It's just kind of, you get another test just for the sake of having a test.
How do people afford the care at the Belize Cancer Center?
You know, at the center, part of our initial goal was to make care accessible to Belizeans, and part of that was whether you traveled, it was a distance issue, was it financial? And financially, we make things available to people if they contribute to care they contribute, and if not, then that's, you know, that's just the way it goes. But the goal is to get people treated and to make sure they have access, because the center could be there sitting there, and but if we don't make the services available to people, then it's pointless to have it.
But how do you sustain yourself if, you know, if it's a pay as you can process?
We're still looking for a sugar daddy or a sugar mama.
It's a no, I mean, you know, I recall a long time ago you talking about trying to solicit donors from your practice in donating medicine to the country. But it's a partnership, isn't it, with the private sector and the public sector?
Yes. The medications used in the center I still buy from my funds, and those are donated to the center. We do get assistance from Social Security, from the Ministry of Health. We depend on donors. The CEO of Caucus Ride, shout out to CEO of Caucus Ride. You know, they've been very generous to us the last few years in with donations, and we have smaller donors here or there, but it's a patchwork to make it all work. I think the biggest deficit that we have is really not on the chemotherapy side. It's really more on treating people who require radiation because of the cost. It's not something that, you know, we can bear the cost of radiation. I think one of the things that we are able to do that's helpful to the people who need radiation is that if they go to Guatemala, where we refer the bulk of patients for radiation, that the facility knows that if the patients came from the center and we authorized it, then they would be guaranteed payment. And so we don't have people who arrive and they get stuck and have to come back home without any treatment. Once you go, you're guaranteed that you will be treated.
You know, I've heard
there's a growing problem in this country, and I know the Cancer Society has been working on a registry to really get a very good understanding of the problem. Some people get diagnosed beyond our borders, some are in private institutions, so there's not as much information as we'd like to know. But anecdotally, everyone knows someone who's been afflicted by cancer. Whether it is within your family or at least just the very extended family that you have. So we know it's growing. We know we see more patients. Do you feel that the system, the healthcare system, is growing in accordance with the problem that we're seeing?
You know, with the issue, on the issue of a registry, when we started, we filled out the chemo, the registry form, and so we have those forms on all of the patients, and we do have a database of our own on patients. But I think more people are getting diagnosed. I think, but some of that is really related to, you know, they just come to within the system now rather than in the past. They may have just died at home and there's old age or something. Or something like that. I think the alarming thing to me, it's actually the younger people who are getting diagnosed with cancer. And when I started in my cancer training many moons ago, breast cancer was a disease of menopausal women after 60. We have 20-something-year-olds in this country with breast cancer, and that's not unusual. To find 30-year-olds, 40-year-olds, fairly common. Colon cancer, the same thing as breast from many moons ago, used to be something in the elderly. Now it's young people in their 20s, 30s, people who you never expected would be at risk for cancer. But I think the big difference is the age creep and from older individuals to people who are much younger now.
Yeah. You know, and like I was about to say earlier, we've heard of many success stories coming out of the Belize Cancer Society Dangriga branch or Dangriga, but what strikes me as well was when you mentioned that you gave up meat for about 20 years. Big deal, which I think is Belize's national meat for about 30 years now. Would you say that this is one of the reasons for this is because that's where we find that you're more susceptible of getting this, getting a cancer?
I'm not really sure what the exact cause is, and if you read, you get multiple stories and theories as to the why.
Yeah.
But I think at the basis of all of it, if you look, there's something called the inflammatory index of food. Mm-hmm. And if you actually look at inflammatory foods, meats tend to be higher up on the highest on that index. And in the relationship between inflammation and cancer, there is an association. For example, if you look at somebody who has a liver cancer develops in people who had cirrhosis of the liver. How do you get cirrhosis of the liver? Whether it's from hepatitis infection or from alcohol, it's actually the drinking and the virus that causes the inflammation that gets you the cirrhosis. And then once you get the cirrhosis, then the liver cancer comes. And so it never really mattered what got you the cirrhosis.
Yeah.
The end result is once you have it, you're at risk for a liver cancer.
Yeah.
And if you look at inflammation within the human body, whether it's heart disease, pulmonary disease, but all those things ultimately get you a disease. So if you can reduce the amount of inflammation in your body, I think it makes a difference.
We've seen where cancer education and awareness is now very closely linked to non-communicable diseases, reminding people that things like your diabetes, your hypertension, your high cholesterol, and even obesity are part of your risk factors in developing cancer. Talk to me about some of the things that you see in practice that you'd wish Belizeans would reconsider in terms of their lifestyle choices.
I think lifestyle-wise, probably the two biggest things are really the top two on the list are smoking and drinking. Thirdly would probably be to just be more aware that cervical cancer is a sexually transmitted disease, and if you're one of the ones who are eligible to be vaccinated, please get vaccinated, and parents, get your young children vaccinated. Vaccination will prevent cervical cancer in the future. I think dietary-wise, Belizeans have gone the way of same way as everyone else in the world, which is fast foods, fatty foods, and the amount we eat has increased. The amount of exercise we get is less. On my way here, I was talking to the taxi man, and we were looking at people along the road, and talking about exercise and how everyone we used to walk everywhere in the past, and and I jump in a taxi to come here.
It's different now and hotter too.
It is.
But bringing it back to the Cancer Center, you've made your first milestone. That's a major milestone of a decade of service.
Yeah.
Where would you want to see it go from here?
The sustainability of the Cancer Center really is something that's on my mind, and that I'm one person, Delone is one person, and we really need to have some succession. And so a part of the future is really ensuring that the center will be able to carry on without me. And in doing that, we're establishing partnerships. I think finding a stable funding source would go a long way to make that happen. There are needs within the country that are purely financial in offering more services to people. So having a better funding source would certainly allow us to do that. Cancer is changing, and there's a lot of new therapies which are very costly. And the ability to bring things like that to Belizeans is something I'd like to do in the future as well.
Do you get a subvention from the government? to run the center?
Some indirectly through the nurses that we get as the primary source of their funding.
So the rest is entirely through fundraising and through
Private, yeah.
what you donate to the center?
Yes.
Have you developed partnerships with other hospitals or clinics to?
The partnership we've developed, and the major one has been with the UCLA Olive View Medical Center Global Medicine Program in Los Angeles, and they send a senior physician as well as 2 resident physicians, internist. The attending physician may be a cardiologist, endocrinologist, but the specialty varies, and they come in 2-week blocks. And our plan for them is really to address something that's not cancer, but really to address some of the chronic issues of diabetes and kidney disease, because the 2 things are so intertwined.
Yeah.
And if we could have better control of diabetes, then we'd see less people who ultimately need dialysis or to lose a limb. And part of their mission is coming here is something I mentioned earlier. You have to take healthcare out to people. And so their outreach programs where they go to the villages and actually see the patients in the village rather than having to come.
Make the trek
Yeah.
across.
Yeah. And so I know at one point there was talk of getting some of the chemotherapy done in the hospital here in Belize City. Are we at that point yet, or?
You know, I'm not sure of that. I think there's a program called Global Oncology that has been advising the hospital as how to best get cancer services to the hospital.
Yeah.
Where they are on that road, I can't say that I'm sure. Dr. Rahman Yaqub is a freshly graduated oncologist who was at KHMH, and we work with him in public and private concert to make sure that patients' needs are met.
Yeah. How do you measure, or what's your marker for success in this venture in establishing the center?
I think success is one of those words that's very slippery.
Yeah.
And but I think one of the things I see of a tangible measurement of success has really been intervention in the pediatric program, which Dr. Pablo Gonzalez in Merida, who works with us to ensure that kids with leukemia get treated. He used to treat patients with Merida as the only available institution, and with all his help, the survival rates were about 38% at 4 children diagnosed with leukemia.
Wow.
And when the center came along and partnering with him, we were able to solve a problem that prevented children from completing the full course of treatment. Leukemia treatment goes for about 2 years. And that requires sometimes receiving treatment once a week for 2 years. And if you could imagine having to travel weekly, that just was not feasible for families. So those children, after they have their acute treatment with Dr. Gonzalez, we do that 2-year treatment here within the country, and that intervention has allowed us to increase that 38% to 78%.
Oh, wow.
And it's still not as other places like the U.S., but it's still a major improvement from where we were.
Yeah.
And I think we can still do better.
Yeah. So definitely, I think that's a tangible indicator in looking at where you have been able to make significant growth. And in working with the adult population, you said you're treating 600 people a year?
No, those are just people coming in for, some people may be multiple, but those are just on chemotherapy infusions being given.
That's here at home.
What's the survival rate that you're seeing? I mean, I know it depends on stage of diagnosis, but.
I would say that probably speaking more in general terms, cervical cancer, we're still tabulating all our data, but I think just rough math says probably about 60% of the people survive at 5 years. And the big difficulty in treating that disease has really been advanced stage at presentation. Breast cancer, I know we're doing worse than that just because there's so many people with advanced diseases, and treatment is harder for them.
Yeah,
You know,
it's a very challenging situation when you think of it, because we have segments all the time talking with health professionals and Cancer Society. Cervical cancer, breast cancer, colon cancer are, the most treatable and also in some cases preventable forms of cancer. But yet these are the cancers, the top cancers, robbing us of our loved ones in this country. And so early detection, I think, is definitely a priority. We keep on hearing it. Is there anything that you can tell people that you look out for as a warning sign? And say, listen, don't take any chances. Don't wait until you feel terribly ill or you fall down sick.
If you see
go to the doctor.
I think part of primary prevention is really not waiting for a warning sign. And that's why doing a pap smear on a regular basis is worthwhile, because cervical cancer can present as someone just having monthly periods where it's just hemorrhage, and even after the period the bleeding continues and continues, and that generally tells you have something there that's bleeding. So that's a sign of disease already established. But just from the point of prevention, you want to have someone take a look and do a biopsy when something is really small and has the potential to grow into a cancer. Colon cancer, similarly, colonoscopy. No one likes to hear a colonoscopy, but the recommended age is typically age 50 to get one. And because if you have polyps within the colon will turn into a cancer ultimately if you don't remove it. So if you have that colonoscopy and they find the polyp and remove it, you saved yourself a cancer. Breast cancer with a mammogram, generally the story goes, by the time you could feel the mass, it's already too late, and because the cancer is already too big. And so you really want to get the things done whether you have symptoms or not, because symptoms generally says you have disease that's out of control already.
Wow.
Now, has the regulations or the guidelines changed for mammograms? Because it used to be age 40. But we know that women are being afflicted by breast cancer much earlier.
I think part of the guidelines have not changed, and part of the challenge in younger women is really the breast tends to be more dense. What do you mean by that when you hear that word? It just means that on an X-ray film it looks all white, and it's more challenging to really pick out abnormalities within all of that whiteness. It's like looking up at a cloudy day and trying to find one spot that's a little bit different that you could pick out, and that's more challenging in younger women. And I think for younger women, it used to be that they would just be dismissed that, I have a mass or I feel something, and it's nothing.
It's always fibroids.
I don't think you really take that answer, whether getting an ultrasound or something, but be your best advocate.
Of course. Of course. Wow.
So, Dr. Grant, when you travel to Belize, as you're here right now, you're working at the center, you're seeing patients. Just kind of let us know what the experience is like when you see people coming in, knowing that it's been over 10 years that you've been able to establish a space where people can access chemotherapy.
I like coming home. The clinic is generally a zoo, but it's fun, and it still feels the same way, and I haven't really gotten tired of it. I think I'm tired of flying, but actually a clinic not clinic. Clinic remains fun. The people we have in clinic, Sister Obi and Pauline, they make it run, they make it work, and something that I look forward to and that patients look forward to as well. I think it's always refreshing when you see somebody who is just so frightened of the cancer diagnosis, and you can talk to them and show them a roadmap to success. And that's how we like to have people leave.
And what makes you, I know there are challenges, I know clearly sustainability sounds like it's an issue that has to be addressed, and looking long term into radiation therapy in country. But with all of that, what makes you hopeful?
You're asking the glass half full, half empty question.
I said the half empty part for you, because those are clear issues, and I know that if we're moving forward, you have to think along those lines, but then you also continue the work, which means there is the essence of hope.
I think Dr. Yakab's presence in the system is hope. I think there's still things within the ministry that need to come together to have them provide the service. And but I view us as really more, we started it, we're here, and we're giving you time to get your act together. And we would like to continue our act forever, but if it's not possible, at least to leave things in a way that it's easier for somebody to pick up and continue on.
Wow. All right. That was a bright conversation. I've got to say, though, the success story continues to come out of the Dangriga Cancer Society, and in terms of people using the services, again, they're right there on Pine Street, Dangriga, and can we find them on site? Just to look up on stuff.
I've never really looked, so I can't.
People find you.
But I think so. I think if you look up it pops up on Google. I think we need to redo our website. Yeah.
I'm sure people are finding you nonetheless. So if someone is at home struggling with a diagnosis and not knowing where the funds will come from, do they just go to the center?
I'd say just call.
Yeah.
Just call, because I think we are aware of the resources available to people, and sometimes even the physicians within the country aren't aware of what's available. But if you call, we typically know what can and can't be done, and can direct people in and give them a roadmap as to how to navigate this process.
And if someone pays for the service at the Cancer Center, what's the average cost per session?
That varies quite a bit because of the types of medications that are used. We're entirely not for profit, and whatever it is that we get, for the person who comes in and they can't do anything, that's the person you're helping. So everyone who comes to the center, you're really helping the next person that comes in, and that's part of how you have sustainability.
All right, Dr. Grant, well, thank you for coming in and just giving us an update as to how things are going at the Cancer Center.
Thank you so much.
All right, we're going to go ahead and take a break, and when we come back, we'll be talking about the 13th Chocolate